Well, welcome everybody. It is my honor to invite everybody and our panelists to our session this evening. This is the Spine and Musculoskeletal Actionable Resources and Tools, the SMART program for TEAM, the Transforming Episode Accountability Model. And this is the first in our four-part series, and we are just delighted to have everybody joining us tonight. The title of our webinar tonight is the CMS TEAM Overview. Impact on orthopedic and spine clinical practice. So just a quick overview of our agenda. I'm going to run through these introductions here, and then we'll turn the program over to Dr. Brueggemann, who's going to give us the CMS team overview. That will be followed by Dr. Amit Jain, speaking on osteoporosis screening and optimization, this key missing ingredient for team success. And then we'll toss it over to Dr. Christian Pion, who will give us real-world insights, preoperative bone health optimization, and fracture considerations. We'll open the floor up for some Q&A at the end, and then we'll adjourn, hopefully right on time at 9 o'clock. I'm Rita Roy. I am the CEO of the National Spine Health Foundation. You can read more about my bio at the end of this topic. This talk, if you want to hear more about it, we'll move on to the speaker intros. And starting with Dr. Adam Brueggemann. I'm going to read through this very quickly. Dr. Brueggemann is an orthopedic spine surgeon at Texas Spine Care Center in San Antonio and adjunct faculty at UT Health Sciences Center. Earlier this year, Dr. Brueggemann was named chair of the American Academy of Orthopedic Surgeons Advocacy Council, a role in which he is responsible for leading the AAOS's efforts to promote and advocate the viewpoint of the orthopedic community before both federal and state legislative, regulatory, and executive agencies. Dr. Brueggemann is also a past president of the Texas Orthopaedic Association and an entrepreneur, where he's chief medical officer at MSK AI, Legent Health, and Empower Health, which is a musculoskeletal-focused company with expertise in neuromonitoring, out-of-network arbitration, and value-based care. Dr. Brueggemann earned his medical degree from the University of Texas Health Science Center, completed his orthopedic residency at the University of Florida, followed by a spine fellowship at South Texas Spine Clinic. Dr. Brueggemann holds a master's degree in hospital administration from Trinity University and a bachelor's in health administration and policy from Creighton University. Our next speaker tonight is going to be Dr. Amit Jain. Dr. Jain is an associate professor of orthopedic surgery, neurosurgery, and business, and chief of minimally invasive spine surgery at Johns Hopkins. Dr. Jain received a BS in bioengineering with high honors at UC Berkeley. He was at Hopkins for medical school, where he was selected for the prestigious Paul and Daisy Soros Fellowship and as the graduating class speaker. Dr. Jain did his orthopedic surgery residency at Hopkins, receiving the Miller-Colson Award for Clinical Excellence and the Bianc Award for Servant Leadership. He pursued his fellowship in spine surgery at Emory to further his interest in health economics and care delivery. He received his MBA from Carey Business School. Dr. Jain's surgical practice focuses on children with scoliosis and adults with degenerative spinal conditions. His research focuses on improving outcomes, safety, and value in spine surgery with over 300 publications and an H-index of 46. He's the PI of an NIH R01 grant on surgical robotics, passionate about education, and serves as the Spine Fellowship Director. Dr. Jain serves as the medical director of value-based care for the Hopkins Health System, where he leads system-wide initiatives on care transformation, readmission, reduction, transitions of care, and value-based contracting. And our third speaker tonight is Dr. Christian Pion. Dr. Pion is faculty in the Department of Orthopedic Surgery at the Duke University School of Medicine, where he serves as the Executive Director of AI and IT Innovation. He holds a secondary appointment as core faculty at the Duke Margolis Institute for Health Policy. An orthopedic trauma surgeon, Dr. Pion's clinical expertise spans fracture care and arthroplasty for fracture care, with a focus on shoulder procedures, total hip replacement for fracture, and post-traumatic hip arthritis, and the management of complex traumatic conditions, including proximal humerus fractures, humerus non-union, periprosthetic fracture fixation, and pelvis acetabulum reconstruction. Dr. Pan's research addresses critical issues in orthopedic surgery and health policy, with over 80 peer-reviewed publications across artificial intelligence, public health ethics, and surgical techniques in orthopedic trauma. His work leverages AI, data science, policy design, clinical care transformation to address population health, and value-based care in musculoskeletal care. Dr. Payan is an entrepreneur as well, where he is the CEO of Revel AI. And so, with that introduction, I went through those very quickly. I will quickly give a background on the Spine Health Foundation. We were launched 5 years ago, built on a 15-year history and research. The Spine Health Foundation is the only patient-centered nonprofit organization dedicated to helping patients overcome the full spectrum of debilitating spinal conditions and to restore their lives. We do this through patient education, advocacy, and research. And we like to say that too often, spine health challenges and musculoskeletal challenges steal life's simplest joys, not because treatments don't exist, but because the path to them is unclear. So the Spine Health Foundation is built to ensure that people suffering from these issues can reclaim the life they love. And we do this by providing trusted information, education, and advocacy driven by the belief that better understanding leads to better conversations, and better conversations lead to better outcomes. Part of what we do is support the provider community as well in areas that pertain to our advocacy initiatives. One of those big areas, a strategic initiative, is in bone health, in spine and musculoskeletal health. So we're really pleased to bring this team webinar in fulfillment of that advocacy aspect of our mission. So just a broad overview here of what we're talking about, the SMART Team webinar series. The Transforming Episode Accountability Model is a mandatory episode-based alternative payment model in which over 700 selected hospitals, acute care hospitals, will coordinate care for people with traditional Medicare undergoing one of the surgical procedures included in the model. Episodes will begin with a hospital inpatient stay or a hospital outpatient procedure for one of the following surgical procedures, and those in bold are the spine and orthopedic procedures, which include spine fusion, surgical hip and femur fracture treatment, and lower extremity joint replacement. Given the predominance of orthopedic and spine procedures in TEAM, this webinar series is designed to educate the orthopedic, spine, and both bone health fields on the model, how to implement it, which will positively impact the work of the Spine Health Foundation to drive bone health optimization and osteoporosis screening, diagnosis, and treatment. And at this point, I would like to thank the sponsors of our webinar series, and that includes Medimaps Group and Radius Health. Tonight's session is session 1, and we're going to just bring an overview of TEAM and its impact on orthopedic and spine clinical practice. And I think that I'm not going to read through the slide. I think we'll just go right into Dr. Brueggemann's talk. He's going to be leading us with the overview. I should let everybody know the Spine Health Foundation's work to drive spine and bone health optimization. A central component of TEAM is the need to coordinate patient care to improve patient outcomes around the 3 spine, orthopedic, and bone health procedures that are in the model. So pre-operative osteoporosis diagnosis through measurement of bone density and bone quality, and treatment alternatives and availability of anabolic therapies in bone health optimization are important aspects to identify underlying osteoporosis prior to any surgery. The Spine Health Foundation has developed a number of healthcare professional educational programs, including this webinar series on spine and bone health optimization, all of which emphasize the pre-surgical osteoporosis evaluation, which includes, everything from DEXA bone density tests, trabecular bone score, and its importance and availability, and CT Hounsfield units. We describe the use of osteoporosis anabolic therapies, and we identify the role of multidisciplinary care, patient education, and post-surgical monitoring in improving surgical outcomes and secondary fracture prevention. You can see all of this work in these resources at our websites.
I happened to be in Congress I happened to be in DC when the model was announced. I was in the basement of Congress, and we had some very surprised members of Congress when this got released. Not expecting something like this, uh, and I think this is a very predictable end to what had happened with CJR and BPCI. And usually, when I give this talk, I give an overview of what's happened in value based care over the years and how we ended up in this model. But here we can see in 2025, this is the data that we have regarding various value based care models that were put together by CMMI. And you can look and see that many of these um, many of these models ended up costing money. So positive numbers are costs, negative numbers are savings. Um, BPCI had $134 million in costs to run it against their $285 million in savings. So it did end up with a slight positive adjustment. But if you look at the original BPCI, which is further down, about 5 up from the bottom, you can see that there was, roughly $500 million in loss on the original BPCI, and then CJR, which is a little bit above it, was roughly $60 million in loss. So what we see here is what was the difference between BPCI and BPCIA, and how can we build upon that? When I say we, I'm referring to the government as they think about it, to make sure that things were profitable. Because at the end of the day, the one thing that CMMI continues to get dinged on is the inability to actually save money. There's been a lot of money set aside for CMMI, which is the Center. Sorry, I used abbreviation. Centers for Medicare and Medicaid Innovation. And we know that total joint arthroplasty, spinal fusions are two of the largest, most expensive procedures performed, both in terms of volume as well as dollar amounts within the Medicare system. And so we needed to find a way, or the government needed to find a way to make it profitable. And BPCIA is scheduled to expire on January 1st. So there needed to be some process that would look like that. So what could they change? Well, making it mandatory. And I know that is probably the biggest fight that everybody had when this first came out, is why is it mandatory? Well, the reality of it is when you've got winners and losers, and if it's not mandatory, then the games theory suggests that winners will stay in and losers will leave. Well, what does that mean? Well, that means that the government's going to lose money, because if only the winners stay in, then they're only paying out revenue to people who did well underneath the model. And if the losers leave, then there's no money to borrow from to pay the winners. And so ultimately, CMMI loses money on yet another demonstration, and they get in trouble. And so they've been advised by multiple people, multiple think tanks, that they needed to have a mandatory model now, no longer having a voluntary model. The other thing that there was, the thought process was, is that we really hadn't tested these models in non-urban settings. So the desire was there to try and make sure that if we were going to do some sort of a nationwide model, which the center is really supposed to be a microcosm of what's supposed to happen in the future. In other words, whatever they come out with out of the center should be translatable to the rest of the country. It should just be a demonstration for a period of time that ultimately gets turned into actual policy. So if we're going to make sure that this is going to work, then we need to put it in safety net hospitals and rural hospitals, which again created some concerns. And so they had to design the model slightly differently to allow for these safety net and rural hospitals to participate without overly burdening them or coming at a significant cost that causes them to close their doors. And then finally, they wanted to make it a shorter window. They wanted to look at things through shorter time period, which we'll go over. So I think Rita did a good job of kind of saying, this is the wording straight from CMS of what the team is. So team model was designed for acute care hospitals. Recognize this. Some of the other models over the years have put the doctor at the center of it, or the doctor is the risk-taking person within the model. In this case, the hospitals are the risk-taking entities. We can talk about at some point in time, maybe in the Q&A, why that might be good or bad, or why that decision was made. at the end of the day, the goal was to ensure that hospitals became responsible for the coordination of care in the postoperative period. Um, the focus was on the things that were successful, which was postoperative care, right? If we look at what was successful during the total joint bundles, it was all in changes in the postoperative care. It wasn't in the actual anchor stay that things were really changing. But if you want to impact post-acute care, you've got to think upstream. And I think this is tonight's talk is a good conversation about one of the areas where we can really start to think upstream and how do we impact long-term outcomes. So what are the hospitals and who are affected and what are the procedures? Well, it's roughly 1 in 4 hospitals in the United States were picked, and I'll show you how they were picked. If they were selected, there's mandatory participation beginning January 1st. If you weren't selected, you actually had the opportunity, I think the timeline has passed, I need to go back and look, but you had the opportunity to submit and state that you wanted to participate as a hospital system. And in addition, it's not in the slides that I pulled for this talk, but physicians can participate with their hospitals. They can risk share. There are some allowances that are being made underneath Stark and anti-kickback, and putting in different things that could be put in place so that doctors could participate with the hospitals. And there are some rules around that. Encourage you to get attorneys to look at it if you decide to participate. The procedures are 5. 2 are unrelated to orthopedics. That is coronary artery bypass and major bowel procedures. And there's 3 that are related to orthopedics: a lower extremity joint replacement, shift, which is surgical hip and femur fracture treatment, and spinal fusions. When the government was going to look to see who they were going to select, they stratified every hospital system in the country, and actually not hospital system, but instead statistical areas. In this case, these CBSAs as opposed to MSAs, but they're pretty closely correlated with MSAs. And so they stratified them based on a handful of statements. So how many safety net hospitals are in there? Is it low or high? Have you ever been exposed to bundled payment models? Is that low or high in that CBSA? Is the average spend for those episodes high or low? And how many hospitals are in there, high or low? And you can see then they stratified these. And then if you look on the far right column, you see how the government decided what the weighting was. So if you were in strata 1, which is the first row, which is low number of safety net hospitals, mostly urban, with very little past exposure to bundling in the past, and had average to low end spend, and had a low number of hospitals within the CBSA, then you had a 1 in 4 chance. Now let's look at the second from the bottom, number 17. This group had a very high number of safety net hospitals. They had a high past exposure to bundled payments, so they'd participated in bundled payments before, but they also had a high average spend, and they had a high number of hospitals within that CBSA. And if that was the case, then they had a 1 in 2 chance. And you can see that there's some different numbers that were put to this, but this gives you some idea of how the government thought through who was going to be engaged or involved in this process. And there was slightly heavier weighting towards certain groups and lower weighting towards other groups. So when it all shook out, here's some numbers to look at, because I've heard a variety of things that I don't think are totally true about how things were selected and who got selected. But if you look at the number of team hospitals by case volume and hospital type, all in, there's 648 hospitals that are going to be selected. And then based on 2023 case volume, roughly 20% of those do more than 500 team episodes a year. 30% of them do between 200 and 500, and 50% did less than 200. And then you can see what the total spending was and what percent of the team spending it was. So the 20% that did greater than or equal to 500 episodes represents about 55% of the team spend. If you look at by hospital category, rural hospitals account for roughly 1 in 5 or 19% of the hospitals that are participating, and 80% of the hospitals are in urban settings. And of that, only about half of those rural hospitals are truly safety net hospitals versus the other half, which are non-safety net rural hospitals. So which patients are impacted? So it's important to know that there are some exclusion criteria. Um, so some exclusion or some inclusion, I should say, are that they have to have both Medicare Part A and Part B. They can't be on a Medicare Advantage plan or some other managed care plan. They can't be on Medicare because they're ESRD or end-stage renal disease. They must have Medicare as their primary insurance. So if they have Blue Cross Blue Shield as their primary insurance and Medicare as a secondary, they are not eligible. And the final one, which probably most people don't see very much of, is the United Mine Workers of America plan. So you can't be covered by that. So we've already excluded half of all Medicare eligible patients because you can't be enrolled in a Medicare managed care plan, and then we have smaller percentages that get kicked out for other reasons. So, this is a little bit less than half of all Medicare beneficiaries end up being accepted into the program if they have one of these episodes. So we talked about duration being shorter. The original duration of most of the previous bundles was 90 days. This is looking at a 30-day period starting with the day of the anchor procedure or the discharge date from an anchor hospitalization. So the DRGs are listed here because sometimes when we say, well, it's this procedure, that doesn't always translate perfectly to DRG codes or HCPCS codes. So the DRG for inpatient and HCPCS codes for outpatient procedures are listed in the center section here. If you have any questions or concerns or worries about what procedures are or are not. What's interesting is that some more things get included in the team episode as far as what counts as payments in that next 30 days after the procedure. So all physician services, all inpatient hospital services, inpatient psychiatric facility services, long-term care hospital services, IRFs and SNFs, home health, hospital outpatient services, outpatient therapy services, laboratory services, DME. Certain biologicals got accepted out, in large part because it wouldn't be fair if you were on a very expensive biological treatment that you needed within 30 days afterwards. It was unrelated to why you were there in the hospital. That would blow everybody's episode every time. So that several of those do get excluded, but many Part B drugs do get included. Hospice services, and then Part B professional claims if they're within 3 days. And so in 3 days prior to the actual procedure. So recognize that they've expanded a little bit what we're going to count as far as costs within that 30-day window, and in some cases up to 3 days before the anchor hospitalization. So then we get to what are the quality metrics by which people will be bonused or penalized. Well, here are the quality measures. So the first year, there's 3 quality measures. All-cause readmission for the whole hospital. This doesn't, not just teen patients, right? So I think we need to be clear on that. This is not just patients who are eligible for teen. This is the whole hospital's all-cause readmission rates. Patient-reported outcomes, PROs, for total hip and total knee replacement, and patient safety and adverse event composite measures. That third one gets dropped off in years 2 through 5, and we replace it with falls with injury, postoperative respiratory failure, and standardized death rate among surgical inpatients with complications. Again, I'm going to say this one more time. Recognize that these quality metrics don't just apply to teen patients. So we are looking at the whole hospital. So as hospitals think about what they're going to do, they can't just say, well, we'll play differently for these teen patients than we do for everybody else. That doesn't work because a lot of these quality metrics ultimately are impacted by other patients outside the teen participation. So there's 3 tracks that everybody gets to participate in. Track 1 is everybody in the first year, and it has upside risk only. You can get up to 10% improvement, but there's no negative, there's no downside. And safety net hospitals get to stay in this track forever. So remember, we discussed that about 10% of all the facilities that got selected were safety net hospitals. Those 10% will stay in track 1 permanently. Track 2 is a handful will go there. And you can see at the bottom who that is. That's Medicare-dependent hospitals, rural hospitals, safety net hospitals, which are in track 1, unless they so choose to go to track 2. Sole community hospitals and essential access community hospitals. They get upside and downside risk, limited at 5% either direction, with reconciliation amounts up to 10%, on positive side and up to 15% on the negative side based on the CQS, which we're going to talk about in a minute. And the final thing is track 3, which is where everybody will ultimately go if you're not one of these select, typically rural hospitals. And you're going to have an up-down 20% potential after year 1. And reconciliation amounts up to 10% under the composite quality score. So what is the composite quality score and how do we get there? So how do we calculate it? So what they have to do is they have to take those quality metrics. Remember, we talked about there were some PROs and some various all hospital scores that were going to be looked at. Well, we take that quality metric and we convert that raw score to a percentile of all national hospitals, not just those in TEAM, but you put yourself up against every hospital across the country and you compare to a baseline, which is 2025. You'll move the baseline as 2025. So the reconciliation is going to ultimately depend on the CQS, this quality or composite quality score. So the first step is we got to take that quality measure and convert it to an initial score. Step 2 is we're going to apply some weighting to it. So if you look at each of the 3 categories that are in year 1, readmission rates, PSI 90s, and the PROs, you can see how those are weighted out based on the volume of episodes that have each one of those. And so based on that, then you'll have a weighting. So in this case, in this example, hospital-wide readmission ultimately was a 38% or a 0.38 weighting. So then from there, you take what you got on that, multiply by the normalized weighting, and you get a weighted score. And what you got on it is based on a scale of 0 to 100. Remember that first column there, scaled quality measure scores against all of your peers, all of the hospitals across the country. How did you do on hospital-wide readmission against everybody across the country? In this case, this person did 60. Closer to 100 is good, closer to 0 is bad. 50 is the average. So then they multiply that by that normalized weight we just looked at based on the number of episodes they had that had hospital-wide readmission, and they get a scaled score. You add up that scaled score for all 3 levels, you get to a composite quality score. In this case, 51.4 in this example. So from there, you ultimately would price that CQS, and that would tell you how much of your savings or loss you ultimately had to pay. So it can count against a loss or improve a saving, or improve or make sure that you get as much of the savings as possible. How do we get to target pricing to determine how much you're going to get back? Well, they took a regional price based on average DRG episode, and they put it by a risk score and a CMS discount, and they get to a preliminary target price. The census regions are what you see here on the map. So there's the Pacific Mountain, West South Central, West North Central, East North Central, East South Central, South Atlantic, Mid Atlantic, and New England. And these are your census regions depending on what hospital you're in. So what's this going to look like? And I'm wrapping up here. Here's some data, and I'm going to go quickly through it so we can get to the other speakers. But the average 30-day episode for specific DRG bundles, we can look at what the anchor stay is, what the Part B anchor is, and what the post-acute looks like. So this is the average episode costs. Take screenshots if you need them, and I can get them out to everybody if you don't get a chance to look at them. Here's how the top 10 metropolitan areas are going to do based on our best estimate. So what you're seeing is the majority of the large hospital systems are going to do poorly. Okay. The U.S. average is going to lose $558 per episode, and the average large hospital system or large market hospital system is not going to do well. The only 2 exceptions to that currently are Nashville and Minneapolis-St. Paul, which both have a current projected gain per episode based on the number of cases, and their average amount that they would have within the TEAM model. So if you look at the U.S. average, here's again a bar graph that looks at some winners and losers. So these are the 5 worst and 5 best. So the 5 best are Portland, Buffalo, Lafayette, Minneapolis, and Raleigh. And the 5 worst are New York, Memphis, Denver, Riverside, and San Jose. And you can see what that would look like in a large gain or loss. And again, the U.S. average roughly about $500 loss per episode. And if you graph this out across the board, you can see there's a lot more red than there is blue, and that's intentional. The government intends to have more people lose than win. Why? Because we talked about this from the beginning. The government needs to win, right? They need money coming in. This is a mandatory model They need the losers to lose to pay for the winners who do win. And ultimately, after paying the winners out of the losses from the losers, they still want some money left over in the pot. So you can see that this graph is skewed to the left with more red than blue, and that is intentional and will definitely happen if the actuaries did their job correctly. It's my final slide. Gives you an idea. This is all of the statistical areas that were selected. More green means more money. More red means less money. So you can kind of get an idea of where people are winning and where people are losing in general. But these are the markets. And again, happy to share all these slides with everybody later. And with that, I'm going to pass it off to Dr. Jane if he wants to share his slides.
Okay, that was great, Adam. Thank you so much. Hello, everybody. My name is Amit Jain, and I am going to be talking about osteoporosis screening and optimization and how that's the missing ingredient for team success. So I'm an orthopedic surgeon at Hopkins. My disclosures are not really relevant here, except we do have some NIH and NIH funding. Some of it is on osteoporosis research. So we know that screening DEXA is a gold standard, yet for patients over 65, especially postmenopausal women or men over 70, yet the screening rates are quite low, and I'll show you some data on that. Younger patients with risk factors, you're supposed to screen them, and really anybody with a history of prior fractures, patients with glucocorticoid use, low BMI patients, smoking history, alcohol use, secondary osteoporosis, all of these patients should be screened. And we know that T-score less than 2.5 confirms osteoporosis, and fragility fracture is diagnostic regardless of the bone mineral density. So in other words, if you have a prior fragility fracture, by definition, you have osteoporosis. It doesn't matter what your DEXA score is. Yet the screening rates are actually quite low. And in fact, this year we had a study that we published looking at CMS claims data from 2017 to 2019 of all traditional Medicare and Medicare Advantage beneficiaries. And what we found is that the bone mineral density screening rates were, extraordinarily low in the target group that should have been screened. So in the traditional Medicare population, about 19% screening rates. In the Medicare Advantage population, only about 22%, despite of it, this being a star rating measure. And then interestingly enough, those who did have osteoporosis, their treatment initiation rates were quite low as well, with traditional Medicare about 20% and Medicare Advantage about 25%. So really, really kind of poor screening and poor treatment across the board. If you look at a kind of national population level data, so when you look at women over age 50, and you look at very specific criteria for what would conclude somebody to be osteoporotic, just applying those criteria at a national scale, about 25 million women in the United States meet the criteria over age 50 in theory for for kind of some kind of a overall osteoporotic type issue. Now, if you look at like how many of those are actually coded as osteoporosis, it's only a fraction of them. And the reason is because a lot of them are actually not screened. And then if you look at what happens to these women over time in terms of fractures, there were almost 10 million unique fractures, which again would give you a osteoporosis diagnosis, but never really gets coded appropriately. And we know that women who are fractured are, despite of having an osteoporosis fracture, are undertreated for this condition. So 83% of folks never really had a diagnosis. 86%, in the state of Maryland, which is the state I am in. And then across the nation, women who were not treated, women who had a fracture, and percentage of them that actually got treatment, was extraordinarily low. In fact, if you look at like the exact drugs for which these women could be put on, such as anti-resorptive drugs, anabolic agents, etc., the numbers are in single digits. So really, really low rates of screening, low rates of treatment. So it's a huge, huge underserved opportunity. When we look at joint replacement, specifically hip and knee replacement, what we find is that almost half the patients who underwent a total hip and total knee were considered high risk for osteoporosis, just based on kind of the endocrinological criteria. Interestingly enough, if you look at what percentage of these was screened for osteoporosis, again, the numbers are quite small. Only about 12% of 12% of total hips and 13% of total knees received a pre-op DEXA scan in the United States. So really, really, again, we're talking, a small fraction here. When we look at even top institutions like HSS, and this is a really nice study out of Joe Lane's group, they looked at 505 consecutive total joint arthroplasties at HSS. And what they found is that 88% of these did not receive bone density testing in the routine perioperative period. So again, very similar to some of the prior data at a national level, indicating there's really good opportunity here. And among patients that were high risk, 90% did not receive any pharmacological treatment for osteoporosis, and only about half of them were treated with vitamin D or calcium in the perioperative setting. So again, huge, huge missed opportunities. When we think about spine surgery, which is my field, uh, we talk about a lot of risk factors in optimization. We talk about osteoporosis being top of that list of things we could potentially optimize. Obesity, malnourishment, diabetes, smoking, all of those things seem pretty obvious. But the osteoporosis, despite of being on the top of the list, often gets neglected and often forgotten. And in fact, we recently put together an abstract looking at screening rates in lumbar fusions. And what we found from the data is of almost 100,000 surgeries, lumbar fusions between 2005 and 2025, 60% of patients were identified as at risk for osteoporosis based on standard criteria, but only almost 3% of men and 10% of women, or 11.6% of women, actually received a preoperative DEXA scan. So pretty low numbers. And why does this matter? Well, there's a number of reasons this matters. First of all, we know that prior fragility fractures are associated with higher risk of complications following lumbar fusion surgery, and we have published on this. And if you look at the data, not just over 1 year, 2 years, 5 years, but almost over 8 years, what you find is that every complication, whether it's revision risk, pseudoarthrosis, mechanical failure, secondary fragility fractures, vertebral compression fractures, all of these things go up with history of prior fractures. So that's really a big deal. And certainly if you're looking at a program like TEAM, those early failures are going to be much higher in the osteoporotic population, which is going to impact your value-based performance. Then when you look at over 3-level fusion, so kind of slightly bigger surgeries, these are patients now with lumbar fusion with a diagnosis of osteoporosis. In another paper, what we found is that there was generally a low osteoporosis treatment. Again, no surprise. 14% of patients were treated prior to the spinal fusion. So very, very kind of low number, surprisingly. And then untreated patients had significantly higher incidence of osteoporosis-related complications. So really, the point is, you got to screen them, you got to treat them, otherwise you're going to be setting your patient up for complications. We looked at another study where we looked at patients with over 5-level fusions. So these are now bigger operations. And we looked at blood loss. And, even the perioperative variable of blood loss, we found that osteoporosis had a 2.5 times odds of major blood loss, losing more than half the blood volume during spine surgery for these bigger operations compared to some of the other factors. So really, it plays a huge role in perioperative management, plays a big role in postoperative complications. And then when we looked at over 8-level fusion, so these are patients who are getting bigger deformity operations, what we found is that a multivariate analysis at a 5-year follow-up, osteoporosis had almost 2x greater revision risk. So again, much higher rate of failing, both in the acute phase as well as over time if you're osteoporotic. And then if you look at patients who had 3-column osteotomies or other kind of big operations for long fusions in adults, what we found is that older age osteoporosis and 3-column were the most common reasons for non-home discharge. So this impacts not only blood loss, but things like, where is the patient going after a surgery? They're going to rehab versus home, which again impacts your value-based payments. And then when you look at the cervical spine, osteoporosis is again quite common in this population, especially the CSM population. What we found is that a lot of CSM patients, which are cervical spondylotic myelopathy patients, are at high risk for osteoporosis and high risk for developing these fragility fractures, partly because of their myelopathy and partly because of undiagnosed, untreated osteoporosis. So it's really a problem in the spine world. When we look at different predictive models of patients who are having these big operations like cervical deformity surgeries, which we do a lot at Hopkins, what we find is that of major complications, the biggest risk factor is really smoking, followed by osteoporosis and kind of angulation of your UIV. So osteoporosis, again, 4x odds ratio of complications, which is quite problematic. We have done cost utility analysis proving that treating these patients works. It's cost effective. A lot of these drugs, especially anabolics, such as teriparatide, romosozumab, etc., are quite expensive. But if you look at the cost utility analysis, it's actually cost effective to treat these patients rather than have them suffer complications from spine surgery like pseudoarthrosis and failures. And we have published on this. So the bottom line is you got to not only screen them, but you got to get them to the right people, usually endocrinology, to get these treated and appropriately addressed so that you're not setting up your patients for failure. So the key takeaways, I hope I was able to convince you that a large number of spinal fusion and joint replacement patients are at risk for osteoporosis. The screening rates are very low. I would say abysmally low, and probably we need to do a better job as a society of medical professionals screening these patients. And when appropriately identified, we got to really use them and get them treated with pharmacological treatment, which is quite effective. The surgical failure and revision rates are strongly associated with osteoporosis. And really, when I think about it, and I think about my role as director of value-based care for Hopkins, it's a huge untapped opportunity because really, if we can screen appropriately and treat early, we can actually not only help patients in terms of quality, but really lower our net costs by avoiding some of these avoidable complications. So I'll stop there, and here's my email if more questions pop up, and I'll hand it off to Dr. Pan.
All right. Those are fantastic talks. I really appreciate the opportunity to speak tonight. I'm going to pull up my slides here. I thought Dr. Bergman's talk should be like mandatory lecture for anybody who practices orthopedics or value-based care. It was probably the most informative overview of the model that I've seen to date. I'm going to take things in a little bit of a different direction. We're talking about bone health optimization and this mandatory bundle and preventing fractures. I'm going to talk about the care episode included in TEAM that is the consequence of not optimizing your patients for their bone health, the hip fracture. And I think that a lot of people are surprised that hip fractures are one of the mandatory bundles included. I would argue that of the care episodes included, this is the hardest one to prepare for because there's no preoperative optimization for these patients. I took care of a few of these patients today, and I meet them where they are. And what I'm going to do over the next 10 to 15 minutes is talk about the way that I think we should be approaching managing these patients in the context of the TEAM bundle, the role that bone health optimization is going to play, and I think also maybe some tools that you can use as you start to participate in this bundle to make this easier. Just very quickly, I do have some relevant disclosures. I'm going to show some technology. I won't name logos or anything like that, but I've been involved in companies that develop technology for care navigation, value-based care. My other disclosures are not relevant. This has been said, I think, time and time over again, but hip fractures in particular are harbingers of really the downward spiral of life for patients. And these fractures happen because we haven't done a great job upstream of optimizing patients for their bone health. 20 to 30% of patients who have one of these hip fractures and are over the age of 70 are going to pass away. Only 30% of patients regain their mobility, and these are very expensive injuries to take care of, and they're only increasing in their incidence in this country. And when it comes to managing hip fractures in a bundle, this is a hard bundle to win. We're talking about patients that are already very frail. You have no opportunity in this case to really optimize the patient. You didn't know that they were going to break their hip. And when you meet them, there's a slew of comorbid conditions to manage. And it's very difficult to contain the post-acute care cost unless you have a plan in place. But let's back up for a second. Yes, hip fracture is included in the TEAM bundle, specifically the diagnosis-related group classifications 480, 481, and 482. is the different categories of these patients with comorbid conditions. There's some risk adjustment criteria. These are not actually the risk adjustment factors that you see in the middle. A lot of the ICD-10 codes that will be used to calculate the risk factors for these patients are similar to the same bundle of codes that have been used to risk adjust in other value-based care models. And just like was discussed in the first few talks today, a large proportion of the spend for these patients is really concentrated in that post-acute care period. And I've had the good fortune of seeing some of the more granular data for different hospitals. If you look at this shift bundle, this is the hip fracture bundle in a de-identified hospital. First off, this hospital is slated to lose quite a bit of money on numerous of these bundles. And this is the typical kind of analytics sheet you can imagine receiving if you're selected for this bundle. But what I want to bring the audience's attention to is this huge bar here of cost for these hip fracture patients. That post-acute cost distribution is really concentrated in the skilled nursing facility. And there's a reason for that, right? Patients sort of flow out of your hospital system to these fragmented rehabilitation facilities. And it's very challenging to wrap your arms around them and coordinate care for them. You don't have a lot of control over the quality of care that's delivered in skilled nursing facilities. The incentives are not necessarily aligned to shorten the duration of stay in a skilled nursing facility. And a lot of these patients are appropriate for rehab. They're frail and older. But what are you going to do in order to target this cost and some of the other costs that we're seeing for these patients? I would argue that one of the things that you can do is pair the patient's surgical pathway with a bone health pathway. I'm going to walk through an example of how we've done this at Duke. But really what we're thinking about is realizing that when we meet these patients, there is still a component of risk stratification. These patients at baseline have a diagnosis of osteoporosis. So we're going to try to close that care gap by discharge planning for them and linking them to a fracture liaison service. And if you haven't heard of this idea of a fracture liaison service, I think that it's also something that should be analogous to just a bone health liaison service for patients who are in these bundles. This is a dedicated service, either a clinic or a provider who is going to be assessing patients for their bone health, prescribing the appropriate medications, educating the patient on why it's important to get their bone health optimized. And what we've done at Duke is pair that bone health and fracture liaison service together with a care coordination service to screen for social needs, to try to help to manage patients' comorbid conditions, contain costs, and improve outcomes. And we really do this over a 6-week period of time. And you can imagine how if you put these services in place and you start to first off measure what matters, right, and understand some of the upstream factors that can contribute to your spend, how quickly you're getting the patients who have hip fractures to operate. That benchmark for us is the number of patients who are getting surgery within 24 hours, how often you're having patients go home rather than rehab. That barrier is generally fairly high, but by concentrating your resources in a way to identify the patients at the time of their fracture who could be amenable to home discharge, you can certainly decrease your skilled nursing facility rate of discharge for these patients. And then by implementing these bone health pathways and utilizing, in some cases, a suite of both coordination services and technology to try to close those care gaps, I think you can really start to not just try to decrease skilled nursing facility utilization, but also diminish the number of ED revisits and readmissions. And this is just an example, right? You're seeing here maybe before, it's sort of the typical kind of path for many patients. You are sort of just doing your job in the operating room, hoping for the best, and these patients float out without any coordination services. A high proportion of them are readmitted. They get urinary tract infections. Many of them end up having secondary fractures, maybe not within the 30-day period of TEAM, but certainly later on. And yes, the 30-day episode of cost ends up being very high. But what we've done is really anchored towards a 6-week time point to have these patients treated for their bone health. And upstream of that 6-week visit, the same person who is helping to coordinate that care is also coordinating calls to the patient and their care support network. We're coordinating that 30-day follow-up with the primary care doctor, which is another component of the TEAM bundle. And we're closing the care gap on bone health, but we're also saving money, right, within the context of this episode of care. So now I'll just walk very quickly through how we operationalize this at Duke. We were not very different from many of the other systems throughout the country. We have a very low osteoporosis treatment rate for our hip fracture patients and really for all of our patients who could benefit from this treatment. And what we did was we put up a big tent, right? And we said we want to bring together everybody who has a role to play in the management of these patients: care navigators, endocrinologists, geriatricians, fracture surgeons who traditionally maybe have not done a great job of understanding that we need to own the bone, so to speak. And we got together and we said, hey, we want to improve care for these patients. How are we going to go ahead and do that? And we came up with this model. We call it the Duke Osteoporosis Value and Excellence Clinic Model. All of the patients who ended up sustaining a hip fracture were systematically screened for social drivers of health, for comorbid conditions that we felt were intervenable. And then we had these patients paired with both a care navigation community health worker type personnel, as well as a direct line to a fracture liaison clinic, which is staffed by a nurse practitioner. And when we started to get in touch with these patients and their caregivers to also coordinate primary care follow-up. And this is sort of what that flow looks like for these patients. And to date, we've managed around 500 patients. A navigator is calling these patients the second that they leave the hospital. Candidly, we've in the past used many EHR native tools, but for a long time, we're just relying on Excel sheets to track these patients. Despite some of the tools that are available, we found that a lot of them were not really up to snuff for tracking these patients longitudinally. And we really saw a dramatic increase in the number of our patients who were treated for osteoporosis. And we also noted that a high proportion of our patients had these risk factors for prolonged skilled nursing facility stay, ED revisit, and readmission present. So this means that a lot of our patients either had caregiver support strain, financial resource strain, transportation access issues, food insecurity. And what we found in our data was that when patients were screened for one of those factors and had one of these factors impacting them, they were twice as likely to come back to the ER. But if we put them in touch with these resources, we saw that post-acute care utilization go down. So I think this was a really phenomenal program that we've implemented, and we're publishing the results soon. And it might feel like, we did it, right? Like we won bone health. But the truth is, I kind of look at this program and having treated 500 patients and feel like it's just a drop in the bucket. There's still, like in this AI-generated picture, a ton of fractures we have to treat. We certainly have not, I think, over the last 5 minutes of what I've described, come up with something that you can plug and play into your hospital system. And even here at Duke, we feel like we're still strained and strapped to try to improve the care that we're delivering to these patients. What we're trying to do now is utilize some of the generative artificial intelligence tools that exist out there. And what I want to do in the last 2 minutes is just show how we are utilizing this technology to educate patients and to close care gaps. What we're doing is coordinating both outbound patient education to the patients, but then also starting to nudge clinicians with surfaced evidence-based guidelines around what bone health treatment is appropriate, trying to help identify the patients who are at risk, and then even coordinating AI avatar videos that get sent to the patients to educate them about why it's important that they try to leave the skilled nursing facility early, why it's so important that they come to the bone health clinic. And this is a video here of our bone health nurse practitioner, Kathy Moreland, actually.
Welcome to the Duke Bone Healthcare Coach Program. I'm Kathy Moreland, lead nurse practitioner at the Duke Bone Health and Osteoporosis Clinic. Today, we'll explore.
And we send these by text message, and we brand these videos. And this entire video is actually generated by AI. Kathy Moreland filmed herself for about 3 minutes, and then we took the transcripts that were related to the patient education and started sending those to them as well.
Regular health checkups are important.
And the way that we're thinking about this is we see a lot of financial exposure. We've implemented a successful care navigation program for these patients, but we just feel like we're not going to be able to do it alone, right? Especially some of these rural hospitals. A lot of the staff that you would depend on to answer inbound calls, to conduct care navigation, they're going to either churn or really be difficult to expand and scale. And so we're trying to plug in generative artificial intelligence and technology to automate outreach through text-based chatbots, through patient education, to flag and help our clinicians identify the patients who would benefit from either earlier care navigation, earlier visits, or bone health bone health optimization, and even for these patient-reported outcome measures. And I think that, my take-home message here, I've showed you a program that we implemented. I talked to you about just how difficult it is to win the bundle with hip fractures. I think at the end of the day, these kinds of cases are really only one in the handoffs. And if you have a fragmented health system and you don't have a skilled nursing facility virtual rounding program or a way to surveil where these patients are leaving, and if you're not screening for some of these factors that can give you a sign of trouble early, then it's going to be really hard to succeed in these models. And I think that there are a ton of evidence-based tools at our disposal to optimize these patients' health, prevent the next fracture, but also to improve outcomes and contain costs in this bundle. And that's the conclusion of my talk. If anyone has questions about how we've implemented this program or the different kinds of tools that we feel are useful to help contain costs and improve outcomes and optimize bone health, certainly reach out. I've got my email here and really appreciate the opportunity to present it alongside these other pretty legendary experts in the field.
Thank you, Dr. Payan, and thank you, Dr. Brueggemann and Dr. Jain. Your very excellent presentations. Really just so much information there and really comprehensive and beautifully delivered. Thank you all. We're going to turn now to Q&A, and we do have some questions here in the chat. I'm going to invite our participants to either submit their questions in the chat and or raise your hand. It's probably easier to put questions in the chat. And so I'll go ahead and start reading these. We've got our first question here is from Mark Ettinger, Dr. Ettinger, who comments that Dr. Jain has clearly shown that surgical outcomes are worse in patients with osteoporosis. When do you recommend slow healing postoperative? Should treatment begin in the initial admission timeframe? And also, remember, in different geographic areas, rheumatologists might be involved. So Dr. Jain.
Yeah, thank you. I think it's important to really identify people who are passionate about this and make them part of your integrated practice unit. It doesn't have to be a physical integrated practice unit. It could be a virtual one, as Dr. Payan described, or really find people who care about this topic, gather them together, whether it's an endocrinologist, whether it's a rheumatologist, whether it's a well-trained nurse practitioner or APP, but somebody who really can get these patients in and provide high-quality advice to these patients to both screen them as well as start them on treatment. I think that's really the key to success.
No, I think it's a good question. I do see this other question on, if I can, I just see, like, since larger callus formation does not inhibit healing, why not start treatment at first hospitalization? I feel like that's directed at hip fracture patients. I think it's a great idea. I think it's been hard to coordinate in the inpatient setting. And there's been, depending on, we've explored this, I don't think that there's anything wrong with starting it. I think that some surgeons and some hospitalists have a varying level of comfort with starting the treatment during the inpatient stay. But I think it's a reasonable model. We've anchored to the 5-week point in part because we had some resistance to the inpatient. I'll be very candid. I'm not sure of the cost of starting the treatment during the 30-day period, and if it's actually disadvantageous for the bundle to do it early. And for that reason, actually, we anchored to the 6-week time point, still capture the patient. Also, kind of be able to deal with the resistance from some people who weren't used to it. But then, candidly, get outside the 30-day window before starting these expensive therapies, unfortunately.
Yeah, at the Academy, we've been advocating for some payment changes related to this because you're spot on. There is a problem there with regards to not just in bundled payments, but as part of the anchor hospitalization, providing IV medications will ultimately hurt the hospital. They don't get paid or reimbursed for it, that they would get paid or reimbursed for post acute hospitalization. So I think everything you just said is right on. And again, unfortunately, payment plays into this and is inhibiting the utilization in many communities.
I'm going to move now to Dr. Rajiv Sethi has a question. Dr. Jain has answered my questions perfectly. He should discuss the importance of IPUs and disease-specific teams, especially important in the management of spine deformity patients. Dr. Jain?
Yeah, I think thanks for the question, and I think Dr. Sethi is a world expert in putting together teams of people who can kind of take care of high complexity patients, such as spinal deformity patients. And I think when you embark on building a spine program, it's really important to kind of identify the appropriate stakeholders, including surgeons, anesthesiologists, perioperative nursing experts, but then really more importantly, all the kind of non-surgical medical folks who can help care for the patients and really come, help with both risk stratification, identification, early treatment, and optimization and months leading up to the procedure. Because some of these elective surgeries are really high risk procedures. So for example, at Hopkins, we actually have a mandatory protocol where every high risk patient has to be, such as a spinal deformity patient in adults, has to be treated by Forteo or temperature teriparatide or Evenity or some kind of an anabolic agent for 6 months for us to consider surgery, because otherwise we consider that to be a contraindication to surgery. So.
We've talked a little bit about DEXA and problems with DEXA being accurate for revealing bone quality, and the differences between, BMD and bone quality. I'm going to put that question out there first to Dr. Jane, and then others. Please comment on that.
Yeah, I think in the spine world, a number of different tools have been used to kind of figure out the appropriate bone density, including DEXA scan, as well as the VBQ score, which is an MRI-based tool, or Hounsfield unit, which is a CAT scan-based tool. I think the point is that regardless of what you use, having a standardized approach for your perioperative team to follow, and then being able to measure something consistently, and then being able to act on it, I think that's probably the most important thing. It's probably not so important to necessarily say, well, one tool is better than the other, etc. But as you can see, based on the large claims data analysis, uh, most people who are at risk are not being screened, period. So doing something is better than nothing.
Yeah, I think it's a huge problem, particularly in the elective space. I mean, when I see hip fracture patients, for example, I know they have, by definition, a diagnosis of osteoporosis by nature of being over the age of 60 and having the fracture. And still, we fail to document it appropriately. We don't do a good job closing the gap. I think it's an even bigger problem for the elective space. And I am treating an increasing number of periprosthetic hip fracture and femur fractures. And a lot of these patients have never heard of osteoporosis. Have definitely had it for years. I think it's just it's in part an education gap. I think it is in part an incentive gap. Unfortunately, there just are not really good, I think, incentives in place right now for surgeons to feel compelled to do this. And, I'm hoping that we use carrots instead of sticks to make it something that is at the forefront of what we do. I think, various societies have been advocating for CPT codes to help to incentivize this kind of coordination. But I think that that's a big part of it, to be honest with you.
Yeah, one of the things that we'll be developing as part of this series is a resource toolkit that will have, some of the tools and other, new technologies and whatnot that are available both on the diagnostic side and the treatment side, as well as information for patients on the care coordination side that you touched on, Dr. Pion. I think, there's question in here about looking at trabecular bone score. Has that improved fracture prediction and reimbursement? And does that move the needle?
I think there's a lack of awareness around TBS or trabecular bone score. And, that would be another, I think, great thing to add in the tool set, right? Candidly, I think there's just a lack of awareness. And then, I'll say, I mentioned barriers to increased bone health screening. Yes, to some extent levers from an incentives perspective. It's also just like workflow. It's just very hard within the thing you're doing day to day, like seeing 50, 60 patients in clinic, dealing with post-op complications, indicating patients for surgery, dealing with prior auth, to then also remember to do this thing. And maybe trabecular bone scoring is one way to automate the process, surface it in a way that doesn't have a lot of friction, and then allow you to act on it. I mean, that can help a lot for sure.
Yeah, I think the TBS is a sophistication built on the DEXA, but the premise is that you got to have the DEXA first. So as the data shows, people are not getting the DEXA, so it's hard to know we can get more sophisticated on that once we have the baseline study. I think one area where I'm interested in from an AI perspective is, opportunistic screening. A lot of people get CAT scans and things like that for a different problem. And I wonder if we can have an AI agent running in the background that just opportunistically screens people and then tags them. And that's kind of a way to do almost like just, in a similar way, we do SDOH screening opportunistically a lot of times. Can we do that for medically specific targeted areas like osteoporosis screening?
It's definitely the challenge on the diagnostic side, having awareness of osteoporosis, looking for it, and then on the treatment side, when to start treatment, anabolic therapies, post hospitalization, and so forth, as you've talked about. It's like I've got another question here. Question is, what AI agents should we start with in osteoporosis care?
I'll avoid naming names, if you will, from an industry perspective, but there are various both conversational AI agents that are patient-facing to enable patients being educated asynchronously about their condition and why it's important to make it to their bone health clinic appointment. That's actually been another barrier for us is, yes, we give you the stack of papers. Yes, we kind of say osteoporosis while you're in the hospital or being seen, to get booked for your total knee replacement, but people forget. And just like these small sort of friendly, frictionless chatbot-based educational tools have been really helpful. For clinicians, there are a few tools that can be surfaced at the point of care together with either an ambient scribe where your note gets documented and it'll actually like preemptively surface questions that you maybe should ask or recommended treatments to consider in the context of patients. I don't want to name industry names, but certainly we can maybe afterwards have a follow-up. But there are several actually also emerging that are specifically targeting bone health, and I think that's a huge opportunity to automate this work for sure.
This is a question directed to Dr. Jane. Dr. Jane, can you share your personal experience on the difficulty assessing pain and functionality in older patients with VCFs caused by osteoporosis as candidates for kyphoplasty and vertebroplasty?
Yeah, I think we could probably spend a whole day talking about that topic because I feel like it's just so pertinent and there's so much nuance there as far as spine care is concerned. But I think every time I see VCF patients, which is quite frequently, at least 2 or 3 patients each time I say clinic, what I find is that the lack of education around what osteoporosis is, the fact that they have osteoporosis, the fact that it's a osteoporosis defining illness, and the fact that it needs, bone metabolic treatment beyond just quote unquote a procedural treatment. It's really mind blowing. And I think, we have developed a whole epic kind of smart phrase, which has literally a whole like 20-page essay on what osteoporosis is, what could be done about it, what you should eat, what type of exercises you should do, who you should see, et cetera, et cetera. But I think, unfortunately, I'm the first person telling them about that stuff, and that should have happened, 3 months, 6 months, 9 months prior to that visit. So the point I'm trying to make is that I think it's really important to have these patient toolkits that the National Spine Health Foundation is developing and other groups are developing to be able to kind of embed into our clinical workflows to educate patients. And then kind of the nuance around vertebroplasty, kyphoplasty, I think that's a much more nuanced conversation.
So just in closing here, I'm just going to invite each of our speakers just to say a closing word or two. I'll start it off with Dr. Brueggemann, since you were our first speaker.
I think this is a unique time. Please engage as an advocacy person, please engage with the government. When this team model came out, there was plenty of opportunity to comment, either engage through your specialty societies. So if you're in spine, North American Spine Society, but you can also engage through the Spine Health Foundation, through the American Academy of Orthopaedic Surgeons or others who are commenting and constantly trying to put our voices together. If we don't comment, we unfortunately have to deal with whatever they come out with. And in many cases, it's not the best. So it's good to be able to be a part of this and shape it. I'm always available if anybody wants to talk.
Yeah, no, thank you so much for a great webinar. I learned a lot personally. I just think value for the patient is really being able to provide high quality care and trying to reduce costs from a patient's perspective. And to do that, we got to put all our heads together and do the right thing for the patient. In this case, screening and treating.
Yeah. I work with a lot of hospitals that are selected for this model and have counseled them on how to succeed. And I would say if you're selected for this, just jump on it immediately because you are underestimating how much work it's going to take to track these patients, to have insight on your data and your finances. And I think you got to start like yesterday. So definitely pay attention to the tools that are out there, start to understand where you stand now and how to start to wrap your arms around these patients. And then I'll say just let your values drive value, right? Like we're on a bone health optimization webinar because we feel like this team bundle, while scary and imperfect, is also a unique opportunity actually to revamp and redesign the way that you deliver care and hopefully to close care gaps like this one to prevent fractures, to improve people's outcomes, contain costs, and just be better doctors and people. So that's what I'll close with.
Thank you, Dr. Pan. And I'll just let everybody know that, so this was session 1. We do have 3 more sessions in this webinar series. Session 2 is scheduled for Monday, November 10th. The speakers are Dr. Sig Bervin, spine surgeon at UCSF, Dr. Brian Cunningham, orthopedic surgeon in Minnesota, and Dr. John Dymar, spine surgeon in Louisville, Kentucky. We will be talking about bone health optimization specifically, implementation to align with CMS TEAM, quality and cost metrics. So we'll be posting about that. So keep an eye out for that. The registration link is live now. And then thank you, David. We'll go in the last 2 sessions, session 3. We are working with our speakers on that to confirm that date. And session 4 will be in the early part of December. And so those 2 sessions are coming up. And then lastly, again, want to thank our sponsors, MediMaps Group and Radius Health, for their educational grant to make this webinar series possible. Want to thank everybody again. There is my contact information. Please feel free to be in touch if you have questions or want to learn more about what we are doing, or want to learn more about the Spine Health Foundation. And David Lee, our bone health lead and partnership lead, is available as well. So I thank you all again. Thank you for joining us. To our participants, thank you very much. To our panelists, brilliant presentations. We are very grateful. Thank you for making this possible for us. Have a good night, everybody.